afternoon. I'll be talking about the clinical features and treatment for both scrub typhus and dengue. Scrub typhus, which is caused by Orangia tsutsugamushi, is transmitted to humans by the arthropod vector of the Trombicridae family. The larval forms are found in the scrubland and in the paddy fields. The average incubation period of Orangia tsutsugamushi in humans is 10 to 12 days, and the onset of the disease is characterized by fever, headache, myalgia, cough, and gastrointestinal symptoms. Patients have a maculopapular rash which starts on the chest and spreads to the limbs. This occurs towards the end of the first week, and regional lymphadenopathy is commonly observed. The most important clue for the scrub typhus is the eschar. So the eschar starts off at the site of the bite. It starts off as a vesicle, which later ulcerates with a black necrotic center and an erythematous margin. The common sites where the eschar is found is in the groin, the genitalia, the thighs, the abdomen, and the axilla. Various organ systems can be involved in scrub typhus. The pathophysiology is a disseminated vasculitis. Patients can have interstitial pneumonia and acute respiratory distress syndrome, acute renal failure, hepatitis. Other GI involvement is like a pancreatitis and diarrhea. And cardiovascular system-wise, there are rhythm abnormalities and myocarditis. And the most common neurological manifestation is a meningitis and a meningoencephalitis. Other manifestations include a transient Parkinsonism, myoclonus, opsoclonus, cereballitis, and rarely transverse myelitis. Some of the more rarer complications of scrub typhus infection include disseminated intravascular coagulopathy. Some patients have presented with a hemophagocytic syndrome. Some of the rarer reports are a transient adrenal insufficiency and a subacute painful thyroiditis. This is a study which was done in CMC, in the ICU, which looked at the profile of organ dysfunction in severe scrub typhus patients. So the mean Apache 2 score was 19.6, and the predicted mortality based on the Apache 2 score was 36.3. The most common organ systems involved was the respiratory system, followed by the hematological system, and the liver and kidneys are also involved. 81% of the patients required a ventilation, and the mean duration of ICU stay was around 6.3 days, and 24.1% was the mortality in this study. So the case fatality can be up to 30 to 70% if no appropriate treatment is received. The median case fatality rate for untreated patients is 6%, and for treated patients is 1.4%. So to reduce the morbidity and mortality of scrub typhus, the treatment must be initiated early in the course of the disease on the basis of a presumptive diagnosis. Patients usually respond promptly with resolution of fever within 24 to 36 hours. So in CMC, for mild rickettsial infections, we give tab doxycycline 100 mg twice daily. And for severe infections, we give IV doxycycline with a loading dose of 200 mg stat. So why do we give IV doxycycline? Because during when patients have a multi-organ dysfunction, there is decreased perfusion to the GI, to the gut, either because of shock or because of use of inotropes. Now, azithromycin is a safe alternative to doxycycline, and it is a preferred treatment in pregnant women. Now, the loading dose of azithromycin is 1 gram stat, followed by 500 mg once daily for 5 to 7 days in mild scrub typhus. This is a meta-analysis which was recently published in JAMA, which looked at the efficacy of various drugs used in the treatment of scrub typhus. They use azithromycin as a reference standard. No other drug showed any increased efficacy as compared to azithromycin. The other drugs which they studied was chloramphenicol, doxycycline, rifampicin, telithromycin, and tetracycline. So there is still a lot of dilemma on which is the best drug which can be used for scrub typhus. This is a study, a systematic review, which was recently published in PLOS, Journal for Neglected Tropical Diseases, which looked at the scrub typhus treatment landscape. So most of the studies which have been published in scrub typhus have actually come from India, followed by South Korea and Thailand. And the common antibiotics which have been used in these studies is doxycycline, followed by azithromycin, and chloramphenicol, ceftriaxone, and rifampicin. Among the studies which had used doxycycline and azithromycin, there were various therapeutic regimens used. The dosing regimens vary substantially among the studies. In doxycycline, the most common treatment regimen was 100 mg twice daily dosing. 2 studies had used 200 mg loading dose followed by 100 mg twice daily. And among the azithromycin dosage regimens, the most commonly used regimen was a 500 mg once daily regimen. One study used a 1 gram start dose followed by 500 mg once daily. So despite being one of the commonly reported pathogens in Southeast Asia, there are only few limited studies, intervention studies done in this. It's a neglected disease in terms of research to inform policy. So there's a lot of heterogeneity among the studies in their methodology and reporting of scrub typhus. And there's uncertainty about the treatment because all the studies have used a heterogeneous treatment regimen. So currently in CMC, the interest trial is going on, which is comparing the use of IV doxycycline versus IV azithromycin versus both IV doxy and azithromycin among hospitalized patients with severe scrub typhus infection. Moving on to dengue clinical features and treatment. So the dengue virus is transmitted by the Aedes mosquito. It's found in the tropical belt. The incidence of dengue is rising rapidly because of urbanization. The WHO has classified dengue into 3 types. This allows for easy identification and appropriate management in sick patients. So dengue, they classified dengue without warning signs and dengue with warning signs and severe dengue. So severe dengue is characterized by severe bleeding as evaluated by the clinician, and it also has severe organ involvement. SGOT, STPT is more than 1,000. There can be CNS involvement in terms of impaired consciousness, and heart and other organs can also be involved. So the cornerstone of dengue management is the maintenance of the patient's body fluid volume. It is very important for us to pick up a patient whether they have a stable circulation or whether they have compensated shock or they have a hypotensive shock. So the parameters which we look at is the mental status, the capillary refill time, the extremities, the peripheral pulse volume, the heart rate, the blood pressure, and the respiratory rate. A good practice is if a patient has a non-severe dengue, they can be followed up on an OPD basis, but we have to carefully instruct them about the warning signs. And we have to clinically assess the hemodynamic status before and after each fluid bolus. And we have to obtain a hematocrit level before and after fluid boluses. And we have to give appropriate IV therapy, just enough volume to maintain a effective circulation during the period of plasma leakage. And we should always interpret the hematocrit levels in the context of the fluid administered as well as the hemodynamic assessment. Some of the bad practices is giving excessive or prolonged IV fluids. And also sending patients with non-severe dengue home with no follow-up and giving inadequate instructions. Now this is a slide on the transfusion of products. So packed cells have to be given if there is loss of blood of 10% or more of the total blood volume, if there's refractory shock despite adequate fluid administration. Platelets, there is generally no role for prophylactic platelet transfusion, even if the platelet count is less than 20,000. But you can give it if the platelet count is less than 10,000 or the patient has prolonged shock with coagulopathy. And FFP is given if there is coagulopathy with bleeding. They have found that thrombocytopenia and acute dengue infection does not correlate with the bleeding risk. In pediatric studies, the only 2 independent predictors of severe bleeding were shock and low hematocrit. Some of the other medications which have been studied in dengue is steroids, intravenous immunoglobulin, statins, antivirals, and N-acetylcysteine. For the rest of my presentation, I would like to highlight the role of N-acetylcysteine in dengue virus infection. Now, N-acetylcysteine is a thiol-containing agent which scavenges free radicals and also causes vasodilation. So in preclinical studies, N-acetylcysteine has shown to improve the clinical manifestations like leukopenia and thrombocytopenia, and has also reduced apoptosis and viral production in the hepatocytes of dengue virus infected mice. So what are the mechanisms by which the N-acetylcysteine acts? It repletes the hepatocellular glutathione stores, it scavenges the free radicals, it improves antioxidant defense, and also causes vasodilation. It improves the oxygen delivery and consumption. This is a study which was done in the Department of Medicine, Unit 5, CMC from January 2020 to July 2021, which looked at the role of N-acetylcysteine in patients with dengue infection. A total of 51 patients were admitted. The mean age was around 33 years. There were equal amount of females and males. The comorbidities were diabetes, hypertension, chronic kidney disease, ischemic heart disease, and malignancy. Most of the patients presented with the primary dengue. So N-acetylcysteine was given for 12 patients. For patients with severe hepatitis, we followed the paracetamol overdose protocol. And for patients who are able to tolerate orally, we gave oral N-acetylcysteine. This was the baseline laboratory parameters of patients who received N-acetylcysteine. 10 patients had a platelet count less than 50,000. 8 patients had SGOT, STPT more than 100. And 6 of the patients had both thrombocytopenia plus a hepatitis. So among the patients who received for a thrombocytopenia, there was increase in platelets to more than 50,000 within 72 hours in 60% of the patients. 63% of the patients had a decrease in SGOT by 50% within 48 hours, and 33% of the patients had a decrease in STPT by 50% within 48 hours. This is the outcome of the patient's outcome in the NAC group. 33% required platelet transfusions, 25% required fresh frozen plasma transfusion. None of the patients went to ICU in the NAC arm. and the length of hospital stay was around 7 days in the NAC arm. It's important to search for promising therapeutic options to prevent dengue virus associated complications. Now, NAC has the potential to be used as a definitive therapy for dengue associated liver failure and thrombocytopenia. We can consider giving NAC when the patients have hepatitis, SGOT, SGPT levels more than 1000 units per liter, and also when the platelet count is less than 50,000 per millimeter cube. But we need randomized controlled trials to establish the efficacy, the timing, the duration, and the dose of N-acetylcysteine in dengue infection. Thank you.
Good afternoon. This is a brief presentation looking at updates on malaria. The presentation is outlined as follows. We will be looking at demographic data from CMC Vellore, treatment updates looking at Plasmodium vivax, evidence on the role of ACT preventing relapse, and treatment updates looking at severe malaria, and the evidence on parenteral artesunate and on intramuscular artemether. In our study, we saw that 502 patients were diagnosed with malaria over a 6-year study period. 245 patients required admission, and of these, 130 patients had clinically severe malaria. It was a predominantly male population, contributing to 81% of all diagnosed, and most of the patients fell into the age category of 30 to 44 years. Vivax was the commonest type of malaria, contributing to 69% of all patients diagnosed, and of all those who were admitted into hospital with severe malaria, a substantial number of patients had only demonstrable Vivax parasite in peripheral blood, and that was 49%. Looking at the month-wise distribution, we see that there was a small increase in the number of cases in the months of August, September, and October after the monsoon. The overall admissions have come down over the last 3 years. This shows the year-wise distribution, and the proportion of patients with falciparum malaria has also been on the decline. If we look at the data from 2015, 61% of patients were admitted with falciparum malaria as compared to 39% of patients with Vivax malaria. And if we compare that to 2019, only 36% of patients had falciparum as compared to 64% who had Vivax. This shows a geographical distribution. Most of our patients come to us from Chittoor, as seen in the northern region. 66 patients had come to us from Vellore proper, and 23 patients were from Katpadi bordering onto Chittoor. A substantial number of patients come to us from Tiruvannamalai as well, specifically from the pocket of Javadi Hills, from where we had 30 patients. We see all these dark green areas which represent heavy forestation, again showing that there's an increased propensity for indigenous transmission in these regions. The state-wise distribution shows us that a majority of our patients come to us from Andhra Pradesh and Tamil Nadu. Other significant states are Bihar, Jharkhand, West Bengal, and Orissa. Jaundice and severe anemia were found to be the commonest features of clinical severity, seen in 32% and 14% of all patients respectively. Among those with falciparum malaria, impaired consciousness, renal impairment, and acidosis was found to be more common. Now, comparing outcome measures to the type of malaria, out of all patients who had falciparum malaria, 62.3% of patients had severe disease, and out of all those who had Vivax malaria, 46% of patients had severe disease. Prolonged hospital stay, ICU admission, ventilatory support, and need for hemodialysis was all more common among those with falciparum malaria, and this was all found to be statistically significant. Putting together all the serious outcomes such as mortality, ICU admission, ventilation, and dialysis, 24.5% of patients with falciparum malaria had a serious outcome as compared to only 5% of those who had Vivax malaria. This had an odds ratio of 6.1, the confidence interval of 2.5 to 14.8, again found to be statistically significant. Now looking at treatment updates, in chloroquine sensitive areas such as ours, chloroquine continues to be the drug of choice, followed by radical curative treatment with primaquine. And we will look at some evidence regarding this. So what about ACT? So let's look at a systematic review, which includes 5 trials done in Southeast Asian countries, in which India is one of them. So this looks at persistent parasitemia and resolution of fever. Comparing chloroquine and ACT, we see that 52 per 100 patients had remained parasitemic at the end of 24 hours, as compared to 22 per 100 patients in the ACT arm, and 29 per 100 remained febrile in the chloroquine arm, as compared to 16 per 100 who remained febrile at the end of 24 hours in the ACT arm. Again, with relative risks of 0.42 and 0.55, which is graded as high and moderate quality of evidence. Now, looking at primaquine for preventing relapse, there's a systematic review of 15 trials, which compares chloroquine with primaquine for 5 days and chloroquine with primaquine for 14 days, again done in Southeast Asian countries. 12 of these 15 trials excluded people with G6PD deficiency, and the remaining 3 did not report on this aspect. So here again, persistent parasitemia at the end of 30 days after starting primaquine was fewer in those who had received primaquine for 14 days or 2 weeks as compared to those who had received it only for 5 days, which was 21 per 1,000 as compared to 183 more per 1,000, with a relative risk of 10.05, which is graded as moderate quality of evidence. Now, looking at the treatment of severe malaria, systematic reviews, which include eight randomized control trials, which looked at parenteral artesunate and compared it with parenteral quinine. So this was done in African and Asian countries. And this looked at mortality, where 109 per 1,000 deaths were seen in the quinine arm and 83 per 1,000 deaths were seen in the artesunate arm with a relative risk of 0.76. Again, graded as high quality of evidence, which tells us that artesunate is superior to quinine here. Now, looking at intramuscular artemether, this systematic review looks at randomized control trials which compare IM artemether to IV or IM quinine, and 2 randomized control trials from Vietnam and 16 trials done in Africa and Asia were included in this. And this looked at mortality, and it shows no difference. There were 170 deaths in the quinine arm and 164 per 1,000 deaths in the artemether arm, with a relative risk of 0.96, and the confidence interval crosses 1, and it's graded as moderate quality of evidence. So at the end of our presentation and our study, we conclude that malaria is continuing to be present, and we continue to see malaria. Vivax malaria can cause clinically severe disease. Falciparum malaria is associated with significantly higher serious outcomes. The treatment of choice for Vivax malaria continues to be chloroquine, followed by 14 days of radical curative therapy with primaquine in chloroquine sensitive areas such as ours. And for falciparum malaria, be it severe or non-severe, it is artesunate, which is a drug of choice, and patients can be treated with initial parenteral artesunate, which can later on be converted to artemisinin-based combination therapy once the patients are able to tolerate orally. Thank you.
Good afternoon, everyone. Today we'll be talking about leptospirosis. So, leptospirosis has been identified as a neglected tropical disease by the WHO. The overall global annual incidence of endemic and epidemic leptospirosis has been estimated to be 5 and 14 cases per 1 lakh population respectively. A recent systematic review found that leptospirosis accounts for nearly 1 million cases worldwide, with nearly 58,900 annual deaths and loss of nearly 2.9 million disability-adjusted life years. With regards to India, it is known to be endemic in our country since the early 20th century, with most outbreaks being reported during the months of October to November from few states of Gujarat, Maharashtra, West Bengal, Orissa, Kerala, Tamil Nadu, Karnataka, and the Andaman Islands. According to recent data from Kerala, number of leptospirosis cases were 1,408 in 2017, 2,079 in 2018, and 1,211 in 2019, with number of deaths being 80, 99, and 57 respectively. In our own state of Tamil Nadu, most cases have been reported from Chennai, followed by Kanchipuram and Kudalur. In 2011, a study found that leptospirosis accounted for nearly 4% of all fever cases reported in 15 private clinics in Viluppuram district. In our district of Vellore, a study to assess the seroprevalence of leptospirosis in 2014 found 10 positive leptospiral cases among 129 humans using the macroscopic slide agglutination test, with Leptospira autumnalis being the predominant serovar. Recognizing the rising burden, the Government of India launched the Program for Prevention and Control of Leptospirosis during the 12th fifth-year plan in all the endemic states. And in 2019, the ICMR reviewed the existing evidence of leptospirosis in order to prioritize the gaps in knowledge currently present. They found that although low-risk occupations were commonly studied on high-risk groups like mine workers, sanitation and slaughterhouse workers, and tribal people were scarce. The most common serovar reported was Leptospira ictrohemorrhagica, followed by Leptospira canalicola. As we all know, leptospirosis is caused by a highly motile spirochete that is best visualized by dark field microscopy and that has a unique question mark hook at one end. With the advent of whole genome sequencing, the phylogeny of Leptospira has undergone a major overhaul. There are now 64 recognized species that are split into 2 clades and 4 subclades, with subclade P1 accounting for most of the pathogenic species. Coming to the mode of transmission, infection usually results from direct or indirect exposure to rodents, which are the main hosts that carry the pathogen in their renal tubules and shed pathogenic leptospires in their urine. The portal of entry is through skin abrasions and cuts, and through mucous membranes of the nose, eye, and mouth. Humans are dead-end hosts. Risk factors include monsoon or rainfall that increases contact with contaminated urine, contact with contaminated water sources, the presence of domesticated animals at home, which may serve as reservoirs for leptospira, flooding, high-risk occupations including farming, mine working, lack of proper footwear, and working in wet and soft soil. Leptospirosis is typically a biphasic illness with an initial bacteremic phase lasting 2 to 9 days, followed by a second immune phase characterized by the development of complications. Most cases are mild and self-limited or subclinical, with vomiting and diarrhea, cough, headache, and arthralgias being the common symptoms reported. Splenomegaly, lymphadenopathy, pharyngitis, hepatomegaly, muscle rigidity, and abnormal respiratory auscultation occur in 7 to 40% of patients. Muscle tenderness affecting the calves is common. Conjunctival suffusion and subconjunctival hemorrhage are often overlooked and often occur in almost nearly 55% cases. Weil's disease, which is a combination of jaundice and renal failure, is the most clinically recognizable form of leptospirosis. High conjugated bilirubin levels, cholestatic pain, and mild elevations in aminotransferase levels are commonly reported among these patients. Acute kidney injury in Weil's disease is common and is typically non-oliguric. It is characterized by repeated occurrence of hypokalemia due to underlying tubular dysfunction and is associated with mortality as high as 20%. The major histology findings include interstitial nephritis and acute tubular necrosis, and several mechanisms have been implicated in the development of AKI. With regards to pulmonary involvement, symptoms include hemorrhagic alveolar syndrome and pulmonary edema that finally culminate in the occurrence of severe ARDS. Pulmonary hemorrhage is the most serious complication in the lungs. Uncommon presentations include cardiac, which may include myocarditis, pericarditis, heart block, and arrhythmia. CNS manifestations are also uncommon and may include meningoencephalitis, transverse myelitis, hemiplegia, and Guillain-Barré syndrome. In rare cases, vasculitis with necrosis of extremities may also be seen. The basis of diagnosis is by serological methods, with IgM ELISA being the most widely conducted test. It has the advantage of providing rapid results and the ability to test relatively early during the course of disease. And it can be carried out on a range of samples, including whole blood, serum, and plasma. However, being a serological method, cross-reactivities do occur. The microscopic agglutination test is the other available test, which is considered the gold standard and provides information on the serovars. However, it is technically demanding and carried out only in reference labs. A single titer of more than 1 in 800 or a fourfold or more rise in titer between the acute and convalescent serum samples is considered to be reasonable evidence of infection. Special techniques including isolation in culture using special media like the EMJH media and antigen detection tests are being developed and are mainly important for research purposes. In the future, these may provide a cost-effective alternative to PCR-based early diagnosis. If you look at the differential diagnosis for leptospirosis, it is wide and encompasses malaria, enteric fever, scrub typhus, and dengue. What I would like to highlight is that in any patient presenting with an undifferentiated febrile illness, the presence of jaundice, conjunctival suffusion, muscle tenderness, acute renal failure, and shock should alert us clinicians to the possibility of leptospirosis. Treatment for mild disease, azithromycin or doxycycline are the drugs of choice. In severe proven cases, parenteral penicillin, doxycycline, and third-generation cephalosporins can be used. We should not use empirical penicillin and cephalosporins because they are not active against rickettsia. Don't use steroids or plasmapheresis in severe pulmonary involvement. There is insufficient evidence for the same. Chemoprophylaxis for individuals in endemic environments is recommended with oral doxycycline 200 mg once a week over the period of exposure. Currently, although certain animal vaccines are available, human vaccines are still in the pipeline. Coming to our experience from our center, we looked at the clinical profile and outcomes of adult inpatients with leptospirosis admitted during a period spanning 11 years from January 2010 to July 2021. Diagnosis was confirmed based on a positive leptospira IgM ELISA and after ruling out other causes of acute febrile illness. Of a total of 3058 patients admitted with acute undifferentiated febrile illness during the study period, 77 patients were found to have leptospirosis and were included in our study. Majority of cases were males with a mean age of 48 years. 32.5% patients had underlying comorbidities and 37.7% patients gave history of ethanol consumption. The median duration of illness prior to presentation was 6 days and the mean SOFA score at admission was 10. Patients most commonly presented with jaundice, vomiting and abdominal pain that accounted for 73, 56 and 41 cases respectively. Most patients had leukocytosis, acute kidney injury, thrombocytopenia and a cholestatic pattern of liver injury at presentation. Nearly 86% patients had multi-organ dysfunction with 3 or more organs involved. The most common organ dysfunction was hematological, accounting for 93.5% cases, followed by hepatic, renal and respiratory, accounting for 87, 74 and 52% cases respectively. The median duration of hospitalization was 9 days. In our population, 27.3% patients required ICU care, with 21% requiring mechanical ventilation and 13% requiring NIV support. Nearly 1/3 of patients had shock at presentation, requiring vasopressor support. Although 74% patients developed acute kidney injury, only 11.7% required hemodialysis. All patients were treated with a combination of penicillin and doxycycline, and survival rate in our study was 98.7%, with only 1 death. In conclusion, in this study of severe leptospirosis infection with multi-organ dysfunction, survival was good, despite high severity of illness scores and predicted mortality of nearly 40 to 50% at presentation. In conclusion, I would like to say that leptospirosis remains an important cause of acute febrile illness in the tropics, and a high clinical index of suspicion is required in patients presenting with severe disease and with hepatorenal syndrome. The incidence of leptospirosis cases is on the rise, and as clinicians, we should be alert to this possibility.